Good afternoon, everyone, and welcome to today's Council on Black Health webinar entitled Successful Translation of a School-Based Physical Activity Program with Low-Resource Schools Before and During the COVID-19 Pandemic. Today's presentation is part of the 2020-2021 webinar series offered by the Council Solutions to Diabetes in Black Americans Core. This core is part of the NIH-funded Center for Diabetes Translation Research at the Washington University in St. Louis. The Solutions to Diabetes in Black Americans Core provides methodological and content expertise to advance the field of diabetes research in Black Americans. We appreciate you joining us this afternoon. My name is Tiffany Eaton. I am a doctoral candidate and graduate research fellow at the Dornsife School of Public Health at Drexel University, where the council is based, currently working with Dr. Shariki Kumanyika, the founding chair of the council. I will be your moderator today. The Council's mission is to develop and promote solutions that achieve healthy Black communities. We leverage the credibility and perspectives of Black American researchers, other collaborators, and research partners to facilitate relevant, community-engaged, actionable strategies that positively impact Black communities. Today's webinar will highlight the successes of a school-based physical activity program tailored for implementation in low-resource settings and how this program was adapted for dissemination in the home environment during the COVID-19 pandemic. During the presentation, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our presenter to respond to after the presentation. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to also use the chat window to interact with fellow attendees. Today's presentation will be recorded and archived for future viewing, and we will publish the webinar online and share the link via email. Our presenter this afternoon is Dr. Rebecca Hassan. Dr. Hassan is an associate professor in the School of Kinesiology at the University of Michigan. For the past 8 years, Dr. Hassan has focused on developing and implementing physical activity interventions in schools, especially for low-income and ethnic minority pediatric populations. As director of the Interrupting Prolonged Sitting with Activity IMPACT program, her team has rigorously tested the feasibility of implementing IMPACT activity breaks in classroom settings and tailored IMPACT to enhance implementation fidelity and flexibility in low-resource schools. Currently, her team is working with Saginaw Intermediate School District to enhance IMPACT sustainability by strengthening district wellness policies, creating train-the-trainer programs, and intermediate school district implementation guides. Dr. Hassan enjoys using her expertise in pediatric physical activity, implementation science, and health equity research to improve the health and well-being of Michigan children and their families. Dr. Hassan, I now invite you to proceed.
Thank you, Tiffany, for that wonderful introduction. And thank you to the Council on Black Health for the invitation to be able to speak with you today about all of the work that we've been doing over the last few years as it relates to promoting equity in our physical activity programming and allowing for all children across our state of Michigan to have an equal opportunity to engage in health-enhancing physical activity. What you're going to see in this presentation is my personal and our lab's personal transition from being health disparities researchers to health equity researchers, because there is a difference between the two, and you're going to see the difference as it's outlined in the data that we present today. But I hope it's encouraging to everyone that even when we face obstacles out in the field, obstacles are opportunities for innovation, and that's what we've been able to do over the last 9 months during this COVID pandemic to still enable our team and the children around Michigan to have equitable opportunities to engage in physical activity while they are at home. So over the last 8 years, as Tiffany mentioned, I have had the opportunity to work with the American College of Sports Medicine and even in my own work to really focus on understanding what are the factors that are contributing to physical activity disparities, particularly among ethnic minority youth, and how can we reduce those disparities. We also had an opportunity with Melissa Witt-Glover to write a kind of a position statement or a special communication for ACSM in terms of how we want to achieve equity in physical activity as an important step to promoting health and health equity across the nation. And as I've been doing work in children and adolescents, I had an opportunity to just kind of review the literature and see what are some of those factors that are contributing to disparities, inequities in our communities that are leading to low physical activity participation. And as you can see here, this is the classic social ecological model, where at each level, our children, African American and Latino children, do have increased barriers to physical activity participation, whether it's less equipment at home, fewer opportunities at school, more sedentary or media devices at home, less support or involvement by their parents due to, again, structural factors as we see, socioeconomic and cultural barriers, as well as barriers in their own neighborhoods and parks and communities. And so once we've identified, and this is pretty well known in the literature, how all of these factors can influence physical activity, the choice to be physically active, we wanted to understand what is working in our communities and what is working in schools. Because schools is probably the place that offers the most physical activity opportunities to our K-12 children. And this is a wonderful figure from David Bassett's research, who did a nice review a few years ago showing what actually works to get kids active. And we see that there are many opportunities for kids to meet the physical activity recommendations of 60 minutes of physical activity each and every day at their schools. The best way is through requiring daily PE, which gives about 23 minutes of physical activity. The second best way is through classroom activity breaks, where about 19 to 20 minutes can be achieved just in the classroom alone. We see that if there are parks in the neighborhood, that provides more opportunities, after school programs, and things like walking to and from school or safe routes to school programming. It also helps children to meet physical activity in their neighborhoods and on their way to schools. But what we know too, if we study this context, is that in each one of these categories, there are disparities or inequities in the opportunities that are available, whether it's that they don't have the programming or it's delivered at a lower quality is very apparent in our low resource ethnic minority schools. For instance, daily recess is not a requirement in many schools across the country. And it may, in many of our low resource schools, we don't have a certified PE teacher there, or it's offered every other day, or children are accumulating less minutes of moderate to vigorous physical activity in that setting. We also know that in our communities, there tends to be parks that are not renovated, but that are perceived as unsafe or unkept. And for many children across the nation, and particularly in Michigan, it is not necessarily safe to walk to school, or there may not be sidewalks available. And after school programming varies in the opportunities that they have as it relates to physical activity. So we really wanted to focus on classroom activity breaks, as that seems to be an opportunity where you can reach almost every single student in the school building, because they are all spending at least 90% of their class day in that room. And if we can train the teachers in how to successfully implement physical activity breaks, that can provide at least the 30 minutes of physical activity that is recommended that schools should provide. So we developed, in response to this need, we've developed with a whole cohort of individuals, the IMPACT program, Interrupting Prolonged Sitting with Activity. We started in 2016, and it was really our goal to provide teachers with the necessary resources to lead their classes in these small, brief activity breaks throughout the day. We knew that teachers would be unable to get a 30-minute block of physical activity, and even a 15-minute block would be difficult for many teachers. So we went to the sedentary literature, the prolonged sitting literature, and we tested in our laboratory beforehand what's the smallest dose of exercise that can produce a health benefit. And we saw just 2 to 3 minutes was sufficient to do that. And so we took it to the classroom to see if we could get 10 3-minutes or 30 minutes of physical activity in the classroom throughout the school day. In preparation for this, we went to, because we were health disparities researchers and we were interested in understanding whether or not our intervention would work well, or this concept of doing brief bouts of activity throughout the day would work equally well in different schools, we recruited 3 different schools to pilot this in. A low income, high income, and middle income school that were all about the same size, but have varying racial composition, varying a number of students who qualified for free and reduced lunch, and various rankings in terms of how they were scoring in terms of academics. And so what we did is we pilot tested this intervention over a 16-week period. We used a ramped up protocol so that it would help teachers to ease into the intervention and to help establish protocols and guidelines for their classrooms. And then we measured the fidelity throughout the 16-week period. My students, Lexi Beamer and Tiwa Ajibowa, who are both PhD students here in the School of Kinesiology, before we went into the school, we developed a whole slew of resources for the teachers to enable them to, again, try to overcome some of the barriers that teachers were already reporting and experiencing in their classrooms. So we developed instructional videos with the help of architects working on the team. We also developed floor plans. We developed, Lexi and Tiwa came up with a 200 activity compendium of activities, so a whole book of activities that teachers could do. We developed teacher manuals to help give the teachers the proper training on how to implement activity breaks in their classroom. We hosted teacher trainings, helped teachers learn how to monitor the students' heart rate throughout the activity breaks, and kept the parents informed of the work that we were doing so that we would have buy-in from the parents as well as the schools. And what did we find? We saw in our intervention after those 16 weeks of this pilot study in the 3 schools, when you look at the data combined, we had some really fantastic results. We saw that the teachers, they were actually able to implement 5 activity breaks. Now we knew that 10 activity breaks was overly ambitious, but the fact that they got 5 activity breaks was fantastic because that still meant that they were getting about 16 minutes of physical activity, health enhancing physical activity in the classroom. We also saw that teachers preferred longer breaks, so fewer breaks that lasted longer. So instead of 3 minutes, they wanted to do 4 minutes. So 5 times 4 would give us 20 minutes in the classroom, which is approximately 2/3 of the recommendations that schools should be providing. And if you remember that original infographic, it's in line with what the research shows in terms of how much physical activity we can actually get in that space. The teachers loved the intervention because they were able to transition their kids quickly as they used some of our classroom management strategies, but they loved even more the fact that 99% of the students were back on task within 30 seconds of completing an activity break. As the biggest fears that teachers have with these activity breaks really focuses on can they refocus the child, their students, after an activity break? And the answer was a resounding yes. We saw that 85% of the students were exercising at a moderate to vigorous intensity, meaning that it was health promoting, and the students enjoyed it and reported that an 8 out of 10 in terms of their confidence in their ability to complete 30 minutes of physical activity every single day. So even though they didn't get that much in the classroom, they were confident that they could get that much with recess, PE, and all the other options that they had. So we were really excited with these findings. And in general, you would probably consider this to be a success. We had some mild media attention related to these findings. We had a commercial made by the Big Ten Network that showcased or broadcast our intervention to schools around Michigan. And so we were really excited until we took a closer look at the data. So let's go through each one of our findings individually to see, were there any differences by schools in terms of the outcomes or implementation? So we already knew that, again, from looking at the data, that the teachers weren't able to implement 10 activity breaks per day. And the overall, it was about 5 activity breaks that we saw in each classroom. But what about for each school? we did indeed see that by school, there were differences in implementation, with our low-income school having the lowest implementation and the high-income schools both having about approximately 5 physical activity breaks a day, where the low-income school had 3 activity breaks. In terms of were students participating at a moderate to vigorous intensity, this was important because, again, we're trying to improve health, reduce any risk that may be associated with inactivity as it relates to obesity or type 2 diabetes risk. And so the fact that 85% of the students were exercising at the right intensity was excellent. But was this similar across schools? The answer was no. That we saw that in the high income school, we saw a nice 92% more of the students were exercising at the right intensity. But if we look at the middle and the low income schools, we actually see only 77% of the students were exercising at the right intensity. So not only were they getting fewer breaks, but they were exercising at a lower intensity. So the total dose of exercise that they were accumulating was much less compared to the other schools. If we look at physical activity enjoyment overall, we said that 4.2 out of 5, that's not bad. But when we looked across the different schools, we did see, again, significant differences in physical activity enjoyment, where, again, this doesn't look like it's a big difference, but when you look at on a scale of 5, 4.0 versus 4.2 and 4.25, it was significantly different. And so we saw lower enjoyment in the students in terms of doing the activity breaks. And finally, when we look at the students, were students transitioning quickly? Again, this was one of the major factors that contributed to whether or not a teacher is going to implement the activity breaks or not. We saw that in general, across all 3 schools, most of the teachers were able to do it in less than 1 minute, which is great because it kept that activity break to about, instead of it being 3 minutes, it was now 5 minutes. And so in total, there was only a 5-minute disruption from the academic curriculum to do an activity break each time they chose to do one. But if we looked across the different schools, this is probably where we saw the most dramatic increase or difference was in terms of the transition time that we saw in the low income school. It took twice as long to transition the students back into a seated position or out of their seat before and after a activity break. And so if you think over time, if you're trying to implement 5, 6, 7 activity breaks a day, that added minute on both sides, both transitioning them up and transitioning them back, was going to be very detrimental to, or a serious barrier to any sort of teacher who wanted to continue to do this over time. If we looked at it by differences in terms of school, of the organization, the entire building, we also saw additional differences as we started to look at things like organizational characteristics, the implementation process, characteristics of the program, the provider, and community level factors. We saw that there were key differences across the different schools as well, with school 1 being the high income, school 2 being the middle income, and school 3 being the low income school. We saw low levels of leadership motivation in our low income school, low levels of communication between the principal and the teachers. We saw low amounts of competing programs, which was interesting. You would think that competing programs would actually be a barrier or a hindrance, but I think what we believed, what this competing programs, since they had low levels of competing programs, that just showed that there was a lower culture of health or less emphasis on physical activity programmings in the school in general. There was less engagement with the youth and also lower provider motivations. So these were key building level or school level factors, as in addition to those individual level student or teacher variables that we saw that were really contributing to some of these differences that we saw in implementation. So if we remember our context and we go back to our figure here that shows us we can get 19 minutes in the classroom, what we realized is that here the problem really lied in that low resource schools provided fewer supports There are a few programs that are tailored specifically for low resource schools, including our own, and low resource schools faced implementation challenges that were unique to all schools. It wasn't just enough to look at the literature and see what are the general barriers. We really needed to take a deeper dive to understand what were the specific barriers that were occurring in low resource schools and develop strategies to help overcome that. So when if we review, what did we see? What did we find? We saw that when you give the same intervention, you're going to have different implementation. And that is what we would call equality in interventions. So we gave the same professional development, we gave the same resources to all 3 different schools, but we saw disparities in our outcomes with fewer activity breaks implemented per day, lower student intensity, lower student enjoyment, and perceptions of the teachers that in that low resource school, there was more student disruption. So how do we move from an equality-based approach to an equity-based approach? And I think this is important for many of our interventions, particularly when we're dealing with diverse populations with diverse needs, that giving similar resources and support to diverse communities, irrespective of the available resources and needs of each school, will result in disparities in the outcomes. One size does not fit all, and so we can't treat all schools the same. An equity lens or an equity approach would really focus on adapting the intervention programming, teacher training, and technical assistance to maximize the program fit and fidelity for each of the different schools. So that's exactly what we did. And this might seem intuitive, but as a health disparities researcher, thinking that we were really tackling all of the major barriers, it was really eye-opening for us to see that we needed to not take an equality or disparities approach, but really take an equity approach in designing our interventions. So what did we do? That's exactly what we did, is we redesigned or tailored our intervention with health equity in mind. So what does that look like? That looks like what we did is we partnered with an implementation scientist, Andy Eisman, who is a faculty member at the Wayne State University in Detroit, Michigan. And she really introduced us to the whole field of implementation science of are there strategies, are there scientific methods by which we can tailor our program to fit the needs or fit the context of the students and the teachers and the faculty that we serve. And what we did is we used the replicating effective programs framework to really help to tailor and develop implementation strategies to make this happen. So strategies that we developed, they were informed by stakeholders such as teachers, the students, the principals, and it helped to enhance our program flexibility and fit. How did it do this? It did this by specifically addressing the barriers that we identified in our low resource schools. And those specific or targeted barriers were there was a lot more competing curricular challenges because of lower performance on test scores and overemphasis on test scores in those schools. We saw differing priorities or competing priorities where the teachers were being pulled in many different directions and physical activity just wasn't on that top priority list. They had limited resources and time for professional development. The perceptions that their students were more disruptive than other students, and then the lack of communication. So each of our strategies really helped to tailor the intervention to address these barriers. And in doing that, it was our hope that we would have improvements in implementation outcomes, that the intervention would be easier to implement for the teachers, and it would be more engaging and fun for the students to participate in, that would thereby lead to improved student outcomes or reaching that dose of 20 minutes of physical activity in the classroom that we saw in our higher income and middle income schools. So what did we do? We were able to partner with another school in Detroit, a low-income school. This was a larger school with many more classrooms that we could work with. Again, it was predominantly non-white, so mostly Latino and African-American population. The overwhelming majority of the students did qualify for free and reduced lunch, And we did see that it had a low ranking in terms of their statewide performance on academic performance. We did have a targeted school, and we were able to work with a school that had high leadership support. So identifying those schools that have high leadership support was key strategy to work with them and work with their teachers to help tailor this intervention to suit their needs. So what did we do? We changed, the first thing we did was change the time frame. So in the first study, the implementation took place in the fall semester. This time we made sure the implementation took place in the winter semester so that it would give us the fall time as a lead up time to work with teachers, work with the principal, work with the PE teacher as well to really help to tailor this intervention to suit their needs. And as you'll see in a minute, we added some game design elements to help increase enjoyment of the activity breaks for these students. So what was the first thing that we did? It was tailor the program packaging. So how was the intervention, how was it packaged, and what were some of the things that we actually modified? Well, one, we modified it by working with the school principal to, again, build capacity and maintain a culture of health within the school. We were partnering also with Project Healthy Schools that also had a simultaneous nutrition intervention going on. And so as we were able to partner with that school, it really did help to bring health and awareness, a culture of health into that environment that I think really helped the teachers build more buy-in as we worked with the principal on these issues. We also worked with the teachers to identify or develop the activity breaks. So we learned originally that most of the teachers, that compendium that we made, while it was fun and cool and exciting, most of the teachers didn't use it. They preferred videos. And so they really wanted to have videos that were freely available to where they could just quickly push a button without having to add in extra prep time to develop an activity break or use one from our compendium to, again, increase that the usability of the intervention. And then finally, for our students, we added in game design elements. So what does that mean? Well, the teacher would nominate a student each day for a daily prize to be who's the impact winner of the day. So the person who is exercising at the appropriate intensity and who is doing their exercise breaks well, they would be nominated and their name would be put into a raffle to earn a t-shirt. Then we also developed weekly prizes to where if the entire class met their physical activity goals of exercising at the right intensity, then they would get a sticker that was placed on their trophy that they would receive. And if they got six different stickers over a 7-week period, they would be eligible for a post-intervention prize. And that post-intervention prize was an impact field day. So 2 hours of structured physical activity that they absolutely loved. And it's amazing how only children can you motivate them to exercise by giving them the prize of more exercise, but it worked wonders just adding in these different goal setting aspects and game design elements. In addition, they were also able to put stickers on a weekly progress graph so they could see how many students were actually meeting the physical activity goals and they could work as a team to do that. So small adjustments to the program that reaped large benefits over time that I'll show you in a minute. We also adjusted the teacher training and the technical assistance that we provided. So in terms of the teacher training, we train the teachers to effectively integrate the activity breaks. So for instance, we had originally really strongly emphasized interrupting prolonged sitting with activity by making sure that there was at least a 20-minute break in between each activity break. We realized that that was not feasible for all of our teachers, that some of them wanted to do 2 in a row. Some of them wanted to actually do 5 in a row. Some of them wanted to space them out on their own, what was conducive to their own schedule. So we really allowed for more flexibility in how they were able to effectively integrate the activity breaks into their schedule. We also developed and emphasized the classroom management procedures. So we developed these different posters that had acronyms on them that would encourage the students provide guidelines for them on how they should transition into an activity break and how they should transition out of an activity break. And we also train the teachers on how to modify their classrooms to allow for the seating arrangements to really be conducive to physical activity. So there wasn't a lot of bumping and pushing and shoving as the students were getting up to do an activity break. And this would be helpful to help help reduce disruptive behavior among the students. Lexi and Tiwa also developed weekly newsletters, and we all held monthly meetings with the teachers to continue checking in throughout the year, that give them opportunities to share their information, share their concerns, troubleshoot, share videos that they really liked. And it really, again, fostered more cohesion among the teachers, that they didn't feel like they were in this all alone. So using the implementation science framework of replicating effective programs to fit the context of this school was how we tailored this intervention to fit the needs, again, using input from the principals and the teachers to help design this. So what did we find? Well, we implemented this in 3rd through 6th grade classrooms. And in the 3rd through 5th grade students, they were able to accumulate 21 minutes of physical activity. So all of the teachers were able to implement 5 activity breaks a day on an average of 255 seconds. So if you round that up, you're getting about 21 minutes every single day of health enhancing physical activity. There was still one group left behind though, and that was our 6th grade students. And while their activity breaks were long enough, the teachers in those classrooms were still only able to implement 2 activity breaks. And so they were in essence receiving 13 fewer minutes of physical activity each and every day. Now, one of the reasons why we saw this was because if you are familiar with elementary school classrooms, that is a contained model where that one teacher teaches one group of 5th grades, 3rd grade, 4th grade students at a time. Whereas in the 6th grade model in middle schools, and because this was a K-12 school, these 6th graders actually rotated teachers. And so not all of their teachers were implementing. We only had a subset of teachers that were implementing and pilot testing the activity breaks. And so in the classrooms where they didn't have activity breaks, the teachers didn't do it. And so there was only 2 activity breaks that they received in a day. So the solution, what do we think needs to happen? I'll tell you that in a minute, but let's just review what we learned here. We did learn, at least from all of the 3rd through 5th grade, that if we design with equity in mind, we can improve the outcomes. We can improve the fidelity, and we can improve the amount of physical activity that the children were accumulating each and every day in their classrooms. But we still need to develop interventions to support 6th grade classrooms, develop supports that ensure sustainability, and help with scale up to increase the reach. So while we're just working in one school, as you know, schools are within districts. Districts are, at least in Michigan, are within intermediate school districts. And there's still a lot of work to be done as it relates to addressing physical activity disparities in the classroom to understand, are there additional barriers that we may be encountering or that teachers may be encountering? And so that is what we're working on now. As we just received funding this year or last year from the Michigan Health Endowment, to where we are now working with Saginaw Intermediate School District to really try to not only address the barriers that are taking place in the classrooms and the barriers, but really focusing on the barriers that are happening at the school level, at the district level, and at the intermediate school district level. We've already developed a nice teacher technical assistance package that's freely available on our website with all the different resources and implementation strategies that teachers can use to provide health enhancing physical activity in their classrooms. But now it's important for us to develop training of the trainer programming to support teachers. And so we're working with regional health school coordinators to make that happen. We also are working with the schools to develop stronger policies. We know that if we want improvements in practice, we need stronger and comprehensive policies. And finally, we're working with the school health coordinators to develop a step-by-step implementation guide. So as we go through, why did we decide to do that model and work at go from a few classrooms all the way, scale all the way up to an intermediate school district? Well, we recognize that there was a lot of system changes that needed to occur in our intervention and just in schools in general to support a program like Impact. That just working in the classroom, it wasn't enough because these teachers are situated in an ecosystem that presents a lot of different barriers. And what we are fortunate to have in Michigan is that we do have this alliance of the Michigan Regional School Health Coordinators Association, which is called MISHCA, to where there is a health coordinator or a regional health coordinator that is assigned to different regions of the state. And as that one health coordinator actually reaches all of the school districts in that region, we have an opportunity to disseminate impact in a much more, scale it up at a much faster pace as a function of this organization and all of the training that they already disseminate throughout every school in Michigan. So in our partnership with Amy Wassman, we've been able to work with her and really support her, train her, as she then trains the 12 to 16 school districts that are under her care that all house different schools within her jurisdiction. And so with Amy, training Amy and working with Amy, we are actually able to reach 32 different elementary schools throughout the intermediate school district in Saginaw. So it's a really wonderful model about how can you scale up and disseminate programming and really, more importantly, address the barriers, the structural barriers that may be taking place in that intermediate school district that is preventing principals and teachers and students from getting adequate physical activity in their classrooms. So what are we doing? How are we doing that? One of the first things that we tackled was Michelle, one of the PhD students working in our lab this year. She evaluated the physical activity policies and looked to see where does Saginaw rank within compared to the national sample, and showed that in terms of promoting policies or promoting physical activity within that intermediate school district, that Saginaw was not doing very well. And they were actually had a much lower, the comprehensiveness of their policies as well as the strength of those policies were much weaker compared to the national average. Then we calculated to figure out, okay, if we added in language into their policies and had buy-in from the superintendents, from the curriculum directors related to providing training for impact through the school health coordinator, and by getting a commitment from them to make sure that they are implementing up to 20 minutes in the classroom each day, by adding that language in, we could substantially increase the strength and the comprehensiveness of their physical activity policies, which would help to enhance the sustainability of impact once it is implemented and into each one of the school districts and school buildings. And finally, Maya, another master's student working in our lab and working on this project, she is developing an implementation guide. Now, this looks like a really crazy, busy slide, but what this actually is a step-by-step guide on how to implement and how to prepare a school district for impact implementation at a school district or even an intermediate school district level. What are the different questionnaires that the health coordinator needs to assemble and administer? What are the conversations that need to take place? What are the gaps in the resources? What's the training needs? What is a future assessment that needs to take place? How is the regional health coordinator going to facilitate communication? As we learned, that was a key barrier. And how are we going to appoint champions, classroom check-ins, and sustain this and repeat this process every single year? Because we know that each school year looks very different than the one before it, and particularly in low resource school districts like Saginaw Intermediate School District, it was going to be important that we continue to adapt the program to fit the needs of this region. And so all of this was taking place and we're doing great and excellent work, but this is also happening in the context of the COVID-19 pandemic. And what is going on in the COVID-19 pandemic and how is it affecting the physical activity opportunities allotted to children? It's affecting them a ton, and we're seeing even more disparities and inequities pop up in physical activity opportunities, not only in Michigan, but across the whole United States and even across the entire world, as this is a global pandemic. We know that from literature that's coming out of Canada that it is projected that there's going to be a 2% increase in childhood obesity solely as a function as the reduced physical activity opportunities that are available to children. We know that that is probably going to exacerbate the obesity disparities and inequities that we already see in our adolescent populations. We know that schools look very different this year. And in these locally controlled schools, like in Michigan, each district decides how they want to administer their curriculum. Some schools are doing virtual, some schools are doing hybrid, some schools are doing in-person learning with social distancing. And they are rotating between those three different models because the COVID pandemic is going through different waves. And so we look at this heartbroken and understand what are we going to do? How can we provide more opportunities for our students in an equitable manner that allows them to still maintain physical activity? Because every item that you see on the right-hand side in this figure has basically been eliminated for most of our students, most of our children during this pandemic. PE has been eliminated in some schools, or it's being taught virtually where teachers cannot actually provide any sort of feedback to the student. Many of the students don't have to keep their cameras on. And so this provides a difficulty in seeing if they're actually exercising. Classroom activity breaks. Some school districts don't even allow the teachers to raise the students' heart rate or breathing rate in the classroom. We know that for many places, parks are still off limits. Sometimes in some places they can, but other places they cannot. Children still cannot access these parks and places. After school programs look very different. And again, walking to and from school became non-existent back in March and has only been reinstated in some areas. So what did we do? We worked together with the School Board of Education. The Vice President of the Board of Education reached out to me back in May of 2020 and said, hey, we need your help. We know you've been doing a lot of work in promoting physical activity in children, and we wanted to see if there's a way in which you can help us to continue to do this during the pandemic. And that is how we ended up transitioning or translating our findings from the classroom into the home environment. I sarcastically said, and I hate sarcasm, but I sarcastically said when they asked, what should we do? I said, well, those of us who exercise, we just exercise at home now. You throw on a little exercise video. Some of us are old enough to remember the Jane Fonda days or the Russell Simmons days, and we can just exercise at home. But then we realized that that was actually a great idea, is to figure out how can we promote physical activity in the home space. In many ways and in many times, that space has been underutilized because it's just so difficult to access. But COVID-19 unfortunately gave us an opportunity to create more physical activity opportunities in that household. So how did we do that? Because she contacted me, Dr. Pamela Pugh contacted me in May, and we had to get something up and running within the next couple of months. So how do you do that? Well, we used another implementation science model, which is the rapid cycle research model, that gave us a step-by-step guide on how do we prepare new innovation or implementation strategy to revamping your intervention so that you can quickly, in a rapid manner, or accelerate the process from idea to concept to testing to dissemination. And that is exactly what we did over a 2 to 3 month time period, is rolled up our sleeves and went through each one of these steps to see how we could better implement physical activity in the home environment. So let's go through each one of these quickly, and I can show you what we did. So first, the preparation phase really focuses on identifying partner organizations and individuals within those organizations who will champion the program. And we had a lot of success in working with different organizations who came on board to say, yes, we would love to work with you. We'd love to help get our kids moving. Many of these organizations have physical activity, exercise, and sport on the front end. That's a key priority in their organization. And so we were able to build this coalition to create an idea of how could we promote physical activity in the home. We then went into exploring this problem. So what does this problem really look like on the ground? And so we had conversations and using a dialogic approach to communication with PE teachers, with our partnering organizations. We conduct, myself, along with some of my colleagues at the American College of Sports Medicine, we conducted a literature review about the COVID-19 pandemic and how it might influence physical activity, equity, and health disparities. And we just really did a lot of the groundwork, whatever was available at the moment, to understand what is the problem and how is COVID impacting physical activity. We then went through a series of knowledge exploration to look at the problem from different perspectives. So again, characterizing that problem, what were all the opportunities that were taken away during the pandemic or reduced? What are the other industries that were facing that same problem? And we hosted a community forum with many of our program partners to have an open discussion about this. Identifying what are the other industries actually doing? How are they managing this? How are they still promoting physical activity? And we saw our colleagues at Playworks and PE teachers were similarly developing videos that could be viewed asynchronously at home. And then what were other people doing that wasn't so successful? Well, this idea of social distancing in person, or even having to cancel programs or having live video conferencing, these were alternatives, but they weren't as successful as developing these videos. So that's what we decided to do. So what did we do? Again, we took the program that we had developed in the classroom that we knew was capable of providing 20 minutes of health enhancing physical activity. And we retain the core elements. So again, using the replicating effective programs framework to identify what are those core elements. So we maintain the intervention dose by making sure the kids were getting 20 minutes. The videos were 20 minutes long. We used exercise videos because that's what the teachers really liked. And we still had the teachers leading the videos. So we were able to recruit PE teachers from across the state to make videos in their backyards, in their homes, as you see right here, and then we just put it on a website and allowed for free access to these videos. And then what were some of the things that were different? Well, instead of promoting the classroom teacher, it was really featuring the PE teacher. We incorporated a series of different health messages, not just about physical activity, but also about social emotional health, about nutrition. These type of messagings were also incorporated. And we wanted to reach not just elementary students, but reach K-12 students all across the state. And we used our media outlets at Michigan to do that. So solution testing, we use the REAIM framework. So this is another implementation science framework. And we determined that of all the different steps that have focused on implementation or solution testing, what had mattered the most at this point in time? Was it the reach, the efficacy, the adoption, implementation, or maintenance? And we realized that it was really the reach that was the most important piece, that we needed to get this out to as many kids as possible in as quick a time frame, because it was a matter of urgency in terms of providing opportunities for our students and helping our schools in our Michigan Department of Education. So within a 2-month time period, we were able to launch the program. And by November, we were already starting to look at the data to see what was our reach. And you can see with each month during November, December, January, we're having a slow increase, slow rise in the reach in terms of how many people were viewing the videos. By January, we were able to, the videos were viewed in all of the different 83 counties within Michigan, but it was also viewed in 48 states, 2 US territories, and actually 27 countries around the world based on our Google Analytics. So it was clear that there was a need, but we still needed to expand our reach, because if you know anything about health disparities or health inequities, and you know about Michigan, a third or 500,000 students within our school districts do not have access to the internet. And so while we had a free available resource available on our website, we needed to take an equity lens and figure out how can we reach this and get this in every child's household. And so what we were able to do is we were able to, through one of our program partners, through the Michigan Public Health Institute, we were encouraged to apply for COVID Cares funding, which enabled us to really build out the program by hiring new PE teachers, having more, redesigning our program website, developing family engagement toolkits. And one of the largest successes is that we were able to partner with Detroit Public Television to develop videos and broadcast these videos on public television through the Michigan Learning Channel. And so now it was launched January 4th, and every child in the state of Michigan can now have access to these exercise videos because they are viewed on TV and they don't need cable or the internet to access them. So, and here is what it looks like if you go on their website. And so it's just been a great, exciting time to be able to disseminate a program very quickly in a short amount of time based on the work that we did in the classrooms and then translating that to the home in the time of need. So I will conclude by just saying thank you for taking the time to listen and engage with me as it relates to promoting physical activity. I just want to say one word that, again, one of the things that really keeps us going in our lab is to really focus on, when we do encounter obstacles, which you always do when you're doing health equity research, it is a great opportunity to innovate. And I hope that I've shown you over the last 40 or so minutes how we were able to innovate, how we used implementation science and a health equity lens to really give an opportunity for all children to have equal access to physical activity, which really enabled us to scale up programs at a time when children needed it the most. I thank you for your time and attention, and I think we have a few minutes for question and answers.
Yes, thank you. So we would now like to invite our participants to post questions using the Q&A button in the Zoom webinar interface, or you can drop them in the chat. Dr. Hassan, this presentation was fascinating, and just kudos to you and your team for the amazing work that you're doing. And, one of my questions, which you just answered, was, with COVID and all the issues with technology access, like how does that impact physical activity? And I love the fact that you put it on the local access channels, and I feel like that was very innovative. And so let's go to some of the questions.
Well, while you're thinking about that, I will address the innovation piece on that. It's funny because we are all the generation of Michelle Obama and the Let's Move campaign. And it's always been a dream to, there should be physical activity on TV. That we always talk about technology, how it's so harmful for our health. And instead of, telling everyone to turn off the TV, is there a way in which we can turn it into something that is healthier? Because nobody's standing away or getting away from their technology. And so how can we harness that to use it to our benefit rather than the detriment of our health? And so when the opportunity arose, I thought that was a 20-year game plan, but it ended up, because of the nature of COVID and how disastrous it's been on all of our communities, the time arose and we were able to take advantage of that platform to really increase dissemination quickly.
Right. And so we have a few questions, all related. Some are related to COVID and some are related to some of the earlier parts of your presentation. But since you were just talking about the innovation, one attendee asked, it seems like the pandemic opened up an avenue for overcoming the challenge in relation to physical activity. And how do you think we can keep this momentum going post-pandemic?
Yes, so that is a great point that we are really focused on. Can we create a new normal? So, because it's not going to go back to the way it once was. Like it's going to be altered in some way, shape, or form once even after all the vaccines are disseminated and we have herd immunity and we're all back in classrooms. But can we continue to promote physical activity in the home? Our long-term goal is to do 20-20-20. 20 minutes of physical activity at home with family engagement resources and programs like Impact at Home, 20 minutes in the classroom, and then 20 minutes of daily, this is where the policy piece push comes, 20 minutes of daily PE. Because while we're promoting physical activity, we also need to give children the opportunity to learn the skills of moving, motor skills, fundamental motor skills. And I think that that's really important for all of those. But I think we do have an opportunity now to give our children the 60 minutes that they're being asked to participate in, and we can do that at a statewide level. So I don't anticipate that Impact at Home will be going anywhere anytime soon, as we just started a new collaboration with the American Heart Association, who is very interested in working with us to promote the program as well.
That's great. Okay, so one attendee asked, leadership support seemed to be important, whether or not the program was adapted to fit schools. What does strong leadership support look like, and how can those doing interventions impact or increase leadership support?
Ooh, that's a great question. Yes, leadership support, I think, is key. And what does it look like? I think it looks like you can actually see it probably on their websites and in their mission statements. That's what we've learned. What are the priorities of the school? And if they have physical activity mentioned in their mission statements, if they have physical activity mentioned in their wellness policies, at a high level, not just the standard language that you see that it's likely cut and paste, but there seems to be some level of commitment to the whole child. We have learned that the principals and the teachers are much more receptive to these types of programs. And when we think about impact, we have really branded it not in terms of it's a new physical activity program that we are bringing into your school, but that we are a training program. That now we have videos because of the pandemic, but we didn't before. But it's really that your teachers are already doing this to some extent, but they're doing it in an unstructured format here and there every once in a while. Why don't we give them training, free training that enables them to implement at a more structured fashion so that you can get the results that you're looking for? And we've always had positive outcomes or positive responses from teachers, principals, and superintendents when you start to look at the data and what it shows about an active kid. A healthier kid is going to learn better. They're going to focus better. It helps with classroom management. It helps with student behavior, give them all of the academic outcomes that they're looking for. That if you just take a few minutes to infuse the physical activity, it will greatly increase the amount of learning time that is going on in the classroom. So that's how we have been successful in identifying teachers. It is sometimes it's not the right time, that is for sure. I mean, we have teachers that are working overtime every single day, same thing with the principals and superintendents. And so it does take, as you saw in that implementation guide, you typically need about a year to lay the groundwork first before you just jump in there and implement. And that's why we're working with Saginaw ISD to really build the foundation first before we go to implement in that large scale up.
So we have more questions. I see in the Q&A, we have a question. Do you intentionally intervene on school culture?
Ooh, that's great. That's a great question. Do we intentionally intervene on school culture? I would say the answer probably honestly is no. That historically we have not intervened on school culture, but I do think now that we are working with a school health coordinator who is already a part of that school culture, that she is going to help us to really focus on how do we increase social cohesion within the school. And I think by changing the policies and by providing more supports, you are indirectly influencing the culture by making it a greater priority within the school. But we have not directly influenced the culture in any way yet. But that's a great question.
And so we had to have a few more questions. Will you be able to stay on just for a few more minutes just to answer a few?
Absolutely.
Okay, I just want to be respectful of your time. So we have another question in regards to the rewards that students received
Yes.
in the classrooms who were engaging in the physical activity. Are there suggestions for additional types of rewards that are not performance-based, just to avoid stigma for students who might not be as active or activity-oriented as others?
Absolutely. So we used at first, I think what you'll have to do is, again, this is where the student voice comes into play in figuring out what do the students want as rewards and how can you motivate teamwork within friendly competition within the class. So what we did in our classrooms is it was a team goal that we really helped to where the entire class, if 50% of the class was exercising at the right intensity, then they would get a sticker. But you could also do it. We also had opportunities for individuals. I think that there's other ways that the students can support the physical activity in terms of if it's not, they can make up their own activity breaks. That's been kind of fun to see. You can ask them what kind of rewards would they want. The goal is though to, help them reach their goals. And by allowing them to set their goals is another strategy to what would they like to do. The only thing you don't want to do is you don't want the prize to be some sort of pizza party, which a lot of the teachers sometimes suggested, or the students for that matter. You really do want it to be health or goal oriented. But I think what we found, which was really interesting, is that, there's a lot of thoughts that it is going to be stigmatizing to the students and they're not going to like it. But we actually saw the inverse in a lot of our results too. In our sample, over 20% of the kids had reported asthma or asthma symptoms, and they actually participated in the activity breaks to a greater extent than the children without asthma. We had numerous students who were at a heavier weight status. And they actually, depending on the type of activity break, whether it was dancing or fitness, they enjoyed the activity breaks to the same extent. Same thing with the girls. The girls were participating at or above the same level of the boys. So I think we're going back to the previous question where you're focusing on building a culture. I think those classroom management strategies of what is the tone that you're setting in your class to reduce that stigma, and how are you providing, making these activity breaks inclusive for all students, and not excluding anyone or not allowing for any student to be made fun of. It really did indirectly increase cohesion, as some of the students and teachers noted that, the kids who might be were disruptive at the beginning of the activity breaks, they actually learned to love them and have engaged in them irrespective of the prizes that they were winning.
And so, Dr. Hassan, you mentioned or you indicated that you needed to do the initial study to identify specific barriers that might affect lower income schools.
Yes.
Could an implementation research design have been used from the outset? Should other researchers or programmers assume the need to adjust the program from outset?
So again, this is the crazy part, is we really did think that we were using a equity lens or we thought that one size fits all, that we were trying to address all of the barriers that had been previously reported in the literature. And the three biggest barriers that we had that was in the literature really focused on teacher time. They don't have time to produce all of these different physical activity breaks, and just the out of time prep was going to be too much. We also knew that the classroom arrangement, so the space in the classroom was not going to be conducive for some because it might be unsafe. Like some of our classrooms had 44 different students in the classroom, 44 sixth graders. I mean, that's a lot of students in a small space. And then problems related to classroom management. So some of those things were actually already developed, already a part of the original intervention. So I was actually really shocked when we saw these disparities in implementation. And so so I would say, to answer your question, that in any school that I go into now, I would definitely do a needs assessment, and for each of the schools or the school district, have conversations, because I think that's one of the major tenets of implementation science, is that it's not a one size fit all, and that while you might have an intervention that is efficacious, that you're going to need to tailor it to fit the environment that you are working in, whether it's low income or high income. So as we went back to some of the higher income schools that we were working in, the teachers didn't like the gamification. They thought it was too much of a hassle, and their students were already doing the activity break, so they opted not to include gamification in their intervention. So I think really focusing on the core elements will stay the same, but those adaptations, those fidelity consistent adaptations, you will likely need to do the work beforehand to see if this is a good fit, if your intervention is a good fit for that context.
Absolutely. And so just a couple more questions and then we can close it out, but both of them are related to policies. And so the first is, can you say more about the type of language you incorporated into the policies to create more sensitivity to equity issues?
Yes, say that question one more time. Read that one more time.
Absolutely. Can you say more about the type of language you incorporated into the policies to create more sensitivity to equity issues?
Yeah, so in terms of policy, so as it related to the impact intervention, the problems that we run into, particularly here in Michigan, is that we will have administrators that are very positively, they favor physical activity, recess, they favor PE, and they will drop these mandates or these policies down and say, okay, every school has to provide 30 minutes of recess every single day in their schools. The problem with that is that the schools don't have the capacity to implement those policies, and then they get out of regulation and then get in trouble because they can't meet the demands that are placed on them by either the state or by their local superintendent. So I think how we are trying to approach equity from a policy standpoint is that we are providing or developing an intervention that will meet the needs or that will meet the policy standard. So as we go into the policies as it relates to physical activity policies, not the entire wellness policy, but as it relates to their physical activity policies, if we are able to work with the schools, enable them to put in language about the impact program and provide that training, by training the trainer, Amy Wassman, we are providing free training to the entire intermediate school district that allows that school district to not only get the training, but then also have the backing of that policy to make it stick. Because a lot of teachers, when you talk to teachers, and the literature confirms this as well, if it's in a policy, then the teachers will make every effort to do it. If it's not, then it will become a second tier item on their mini long to-do list. And so really helping them by providing the training, providing the resources, making the program easy and flexible for them to do, that you have a program that matches the policy so then you can have equitable practice. And that's how we're approaching it.
That's great. And so the last question, one attendee says that they found that people sometimes think of the evidence base as a static set of best practices and can get uncomfortable when faced with the idea that applying the evidence has to be dynamic based on the context in which you were working. And so what are your thoughts about how we start to translate the need for variability and adaptation to policymakers as the evidence base, or any lessons learned from the scale up to the higher levels of the school districts?
Yeah, so I mean, I think that that's where the equity piece comes in, is that you have to be open, we have to be open to, and there, you know, the NIH and our funding agencies are recognizing this as well, that we have to be open to adapting our program. There is really no such thing as a static program, because the static program is always going to become ineffective over time, because that even if you just think within one school district, and when I've worked in school districts, when my students have worked in school districts, we'll train a group of teachers to implement. You go back 1 or 2 years later, those teachers are gone. They've either retired or they've gone to another school district. And so you have a different group of implementers just a couple of years later. You might have, we know that in low resource schools, the superintendent, the average expectancy time in which they are in that job at that school is about 2 to 3 years. So everything is changing. You are trying to quote unquote implement something that is stable in a very chaotic, for lack of a better term, ever-changing ecosystem. And so if you want your program to be sustainable, through implementation science and even through health equity research, we have tools and principles to continue to adapt our programs to fit the context, whether it's the same context or whether it's adapting it to work in another context. And so I would encourage all interventionists, if you don't want to have disparities in your outcomes as we did, and unfortunately there will always be needs for improvement in our interventions, because the children change as well, and they develop and their interests change, that you will always want to be having some component of your intervention that is open and flexible for adaptation. And so that's where implementation science really comes in, because they help you to identify what are the key core components of your intervention that should be the same throughout all different programs. And then what are the key parts of your intervention that can be adapted? Because whether you believe it or not, your teachers are going to be adapting it to fit their context, whether you allow for it or not. And so you'd rather that they are adapting your intervention with fidelity consistent adaptations rather than fidelity inconsistent adaptations, to where the effectiveness of your program is not sustained because of adaptations that they made. But if you can work with them to figure out how can we make this fit in your environment, I think that you're going to have something that they'll want to be more inclined to adapt and include, and then you'll also have a program that can be sustained for a longer period of time.
And so this is all amazing work. Thank you. I don't have any more questions to share. And just again, thank you, Dr. Hassan, for this informative presentation on all your work with the school-based physical activity program, you're applying the health equity lens, and the adaptations during the COVID-19 pandemic. And so on behalf of the Council on Black Health and the Solutions to Diabetes in Black Americans Core, I would also like to thank our attendees for participating in today's webinar and staying with us a little longer this afternoon. We will share an evaluation survey for this webinar shortly, so I hope you all have a pleasant afternoon.